Hello, my name is Karen Puopolo. I'm a neonatologist at Children's Hospital of Philadelphia in the United States. I appreciate the opportunity to present today at the International Neonatology Conference, and I'll be speaking with you about acquired cytomegalovirus infections in the preterm infant, epidemiology, and outcomes. I have no financial disclosures. The presentation will refer to, but not endorse, the off-label use of ganciclovir for the treatment of postnatal CMV infection in preterm infants. These are our learning objectives today. Cytomegalovirus, or CMV, is a ubiquitous human virus. It's double-stranded herpes virus with numerous strains. Transmission can occur horizontally by direct person-to-person contact, usually via saliva. It can also occur via blood transfusion and organ transplant. And most important to us today, it can be transmitted from mother to infant before, during, or after birth. And after birth, one of the sources of CMV infection is breast milk. As a ubiquitous virus, most adults encounter it in childhood, and many are infected and immune by the time they reach adulthood. The seroprevalence to CMV does vary in different countries across the world, and even within the United States, there is some variation that exists from state to state by race and ethnicity and by socioeconomic status. The issue of how CMV is transmitted from mother to newborn was studied in great detail in seminal work done by Stanio and colleagues in the late 1970s. In an important study, this group did serial testing by CMV culture during pregnancy and during the postpartum period from nearly 400 women, testing cervical secretions, urine specimens, and saliva specimens from these women. 278 of the women also contributed breast milk or colostrum samples. And CMV was detected in the milk or colostrum of 38 of these women, or 14% of the cohort. From here, the investigators focused specifically on the role of breast milk in transmitting CMV. They identified 28 women in whom CMV had only been detected in breast milk or colostrum and had not been detected in any cervical, urine, or saliva specimen. Among these 28 women, 19 of them were breastfeeding and 9 of them were formula feeding their infants. The infants were serially tested throughout infancy, and ultimately 11 out of the 19 breastfed infants, or 58%, became CMV positive, and none of the 9 infants who were being bottle fed became CMV positive. The infants were found to be infected with CMV anywhere from 4 weeks to 4 months of age, although there was one outlier at 9 months. Interestingly, the infection rate that was observed in the study was almost exactly the same as the infection rate observed when women had CMV found in cervical secretions at the time of vaginal delivery. In this study that focused on term and otherwise healthy infants, none of them who are identified as being CMV positive became clinically ill. And ultimately, no differences were found in neurodevelopmental outcomes in early childhood, and this included assessments of the children's hearing and vision. On this study, published in the New England Journal of Medicine in 1980, the investigators made this statement: because the infection produces minimal morbidity and leads to chronic shedding of virus into urine and saliva, it must be viewed as a form of natural immunization. And they concluded thus the minimal risk associated with transmission of CMV through breast milk is clearly outweighed by the well-established value of breastfeeding. The topic of our conversation today really comes down to, does this statement apply to preterm infants? Specifically, what about baby G? So baby G was an infant cared for in our NICU here in Philadelphia. Born at 23 and 6/7 weeks with a birth weight of 520 grams, this infant was tested for CMV shortly after birth and was found to be negative. At day 40 after birth, the infant was stable on CPAP support, getting full enteral PG feeding with a combination of fresh and frozen mother's milk. On day 41, the child acutely became ill with a respiratory decompensation and required reintubation. A sepsis evaluation was done. It revealed neutropenia, a new onset thrombocytopenia, and an elevated CRP level. Blood cultures were sent, antibiotics were given, and a urine CMV was sent as well. So I would hazard to say that if I told you that baby G grew Klebsiella pneumonia from those blood cultures, you would know how to treat with antibiotics. You would worry that the infant would now have an increased risk of death or BPD, a prolonged length of stay in the NICU, and you would worry that there'd be an increased risk for neurodevelopmental impairment on the basis of this infection. And you would wonder what lapse in infection prevention had led to this infection. But if I told you the blood cultures were negative and the urine CMV PCR was positive, you would call your ID consult, who would be uncertain as to the value of ganciclovir treatment, which is the antiviral treatment of choice for CMV. You would be uncertain about the potential additional impact of this infection on the infant's risk of death or BPD, risk the length of stay in the NICU, and ultimately the child's neurodevelopmental impairment risk. And you would wonder and maybe doubt whether there was anything you really could have done to prevent this infection. So how do we answer these questions? In the next few slides, I'll review what we do know about the epidemiology of CMV infection among preterm infants. Studies of CMV detection in our babies have benefited from the development of additional methods of CMV detection. The studies that were done in the 1970s were all done by traditional cell culture for virus, the results of which would take up to 3 weeks. Rapid culture methods, which look for the expression of early CMV antigens, are quicker and can give a result in 1 to 2 days. Nucleic acid-based methods of PCR are now in wide use. You can use them on blood, although they have low sensitivity on dried blood spots, urine, or saliva, and they are very sensitive, pretty specific, and detect some cases that are culture negative. Postnatally acquired CMV does need to be distinguished from congenital CMV, which is defined as CMV infection detected at less than 2 weeks of age. And this is usually attributed either to transplacental transmission of the virus or to intrapartum transmission via infected cervical secretions. In the United States, the CHIME study has definitively demonstrated that the incidence of congenital CMV in the overall birth population in the United States is about 0.5% or 1 in 200 live births, and only about 0.5% of those seem to have an expression of illness from the infection. Very low birth weight babies are not different in incidence, although this is a less well-informed area. One NICU in Alabama reported on their experience routinely testing very low birth weight babies for CMV within 2 weeks of birth on admission to their NICU. In this report, 18 out of 4,594 infants, or about 0.4% of them, were found to have congenital infection, not different from the overall birth population. So how do preterm infants acquire postnatal CMV? Well, prior to contemporary blood breaking practices, transfusion was a source of acute CMV infection among preterm infants. With the development of practices that focus on CMV negative donors and on leukoreduction of transfused units, that is the removal of white blood cells, which are often the source of CMV within the transfused product, blood transfusion has largely been eliminated as a source. Yet it was observed that preterm infants still seem to acquire postnatal CMV. A number of centers have done surveillance studies to determine what the etiology of these infections would be. And I highlight one here that was published in 2001 from a German site. In this NICU, infants with birth weight less than 1,500 grams and gestational age less than 32 weeks, all of their mothers had CMV serology obtained shortly after infant admission to the NICU. The infants underwent biweekly CMV tests on their urine, and every couple of weeks among breastfed infants, samples of breast milk were tested as well. Anytime an infant was noted to have acquired CMV infection, the infant was assessed for symptoms with an onset about 1 week prior to the detection to 2 weeks after the detection to determine if the infection was symptomatic or asymptomatic. In this report, CMV was detected in no infants born to seronegative mothers, and in 38% of infants born to seropositive mothers. Of those 38, about half of them were considered to have a symptomatology attributable to the CMV infection. Still, questions have persisted about the relative role of blood transfusion versus breast milk acquired CMV. Concerns that really should be definitively put to rest by a publication, by a study that was done by Josephson and colleagues in 3 Atlanta, Georgia NICUs and published in 2014. And this study included 462 mothers who gave birth to 539 very low birth weight infants. All of the mothers were tested for CMV antibody after birth, and women who were CMV negative were tested by PCR at infant discharge to ensure that they had not acquired CMV during their infant's care. The infants were tested shortly after birth to rule out congenital CMV, and then at specific intervals and at any time there was a clinical suspicion for infection. What made the study unique is that all of the blood products administered to these infants during their care were tested for CMV by PCR, and were also tested by methods to detect any failure of leukoreduction. Finally, breast milk samples from women who were providing breast milk for their infants were also serially tested up to about 6 weeks of infant age. First, I'll report that the blood products had no CMV. Of the 1,038 units tested, all of them were CMV negative, and only one platelet unit had residual white cells detected. This unit had no CMV and was not associated with a CMV infection. So how much CMV infection was there? Of these 462 mothers, 352 of them were CMV positive, the rest were CMV negative. During the course of the study, 29 infants acquired CMV infection. One of those 29 was considered to be a congenital infection, and no cases of CMV occurred among the infants born to seronegative mothers. All 28 infants had been fed breast milk, and CMV was detected in the milk samples in 27 of 28 of these cases. And this study can really be viewed as sort of the definitive evidence that in the setting of modern blood banking practices, very low birth weight babies can acquire CMV. They do not acquire it from blood transfusion, and they do seem to acquire it when fed breast milk from mothers who are infected with CMV at some point in their lives prior to the baby's birth. So what were the outcomes of the CMV-infected infants in this study? There were 28 infants again, which represented 6.8% of the at-risk very low birth weight babies in the study. 5 of the cases were considered to be symptomatic. In 3 cases, the infants died. All of them had developed a neck-like illness, and one death, however, was attributed to CMV pneumonitis. One of them had a sepsis-like syndrome but survived. One also survived but developed basal ganglia calcifications that had not been seen on prior imaging. But interestingly, there was no clinical suspicion for the infection in 24 cases, including the congenital case. There are a number of other case series in the literature describing a sepsis-like syndrome attributed to postnatal CMV infection in very low birth weight babies. A particularly disturbing report was one from a center that reported on 5 cases of sepsis-like syndrome attributed to CMV. This apprised 15% of all of the infants born at 23 to 28 weeks at the center over a 2-year period. In this publication in 2010, all of the infants were born at low gestation. All of them acquired presented with a severe sepsis-like picture anywhere from 6 to 8 weeks after delivery. All of them, at the time that they presented, were on non-invasive respiratory support and full volume feeding. One of the 5 was reported as dying of the infection. One went on to have severe lung disease requiring tracheostomy, and 3 did recover. In investigating these cases, the authors report that CMV viruria and viremia was identified in all cases. Multiple cultures of blood, urine, and CSF for bacterial pathogens were negative, other than one case of Klebsiella. All of these infants had been fed fresh mother's own milk, and CMV was isolated subsequently from each of these mothers' milk. All of these infants in this publication were given ganciclovir with a 1-log reduction in viremia, but with variable clinical improvement. So what overall are the characteristics of preterm postnatal CMV infection? As suggested by the studies that I've highlighted, there tends to be an onset of viruria approximately 6 weeks after birth. And because this primarily impacts very low gestation infants, it tends to occur at an adjusted age of about 33 to 36 weeks gestation. There are multiple reports of these severe cases, which present with a sepsis-like illness. But overall, the literature on postnatal CMV is dominated by less severe and often silent disease, identified either by surveillance practices or by the somewhat happenstance identification of thrombocytopenia or abnormal liver function tests. The risk factors for acquired postnatal CMV are dominated by lower gestational age and birth weight. This is a disease primarily of infants born under 28 weeks gestation. Other risk factors include the volume and duration of breast milk feeding, a higher versus lower viral load in the breast milk, and there is some role for CMV-specific antibiotic in breast milk. Obviously, maternal serum antibody as well as antibody in milk is not entirely protective, but higher CMV-specific IgA levels do seem to correlate with lower risk of acquisition, and higher IgG avidity in milk seems to be associated with lower CMV viral load. Investigators at CDC performed a meta-analysis and did population estimates for the overall impact of postnatal CMV on very low birth weight infants. This study was published in Pediatrics in 2013, and it included 17 studies that had been published in the 21st century, predominantly from Europe and North America. The study distinguished the estimated risk of any form of postnatal CMV infection and the risk of sepsis-like syndrome from CMV infection in the study infants, and then translated that to the VLBW population. Interestingly, the risk of any CMV infection was a little bit lower with frozen milk versus fresh milk, but severe sepsis-like syndrome, the point estimates were not different, and I've highlighted that here, perhaps arguing that even at a potentially lower viral load in the milk, the most vulnerable infants who are going to get severe disease can still get it. The population estimates come down to this: accounting for the seroprevalence in different populations and the differential risk across the gestations represented in a birth weight less than 1,500 gram population. CDC estimated that roughly 1.5%, anywhere from 1 to 2% of all very low birth weight infants were at risk to develop severe disease from postnatal CMV infection. So now we'll talk about some outcome studies. What is the impact of these infrequent infections, and should we worry about it? The literature on the impact of postnatal CMV infections has focused for many years on the association with bronchopulmonary dysplasia. There are many smaller studies published in the 20th century. I'm going to focus on 3 larger, more contemporary studies. The first study is a single center study that focused on infants born at less than 1,250 grams. This was done at one of my centers in Boston. It was a nested case cohort study looking at 19 cases of infection in a cohort of 1,080 infants. And it used a regression model adjusted for a variety of predictors of both infection and outcome. And in this single center study, the odds ratio for developing BPD was 4.0. with the 95% confidence interval demonstrated here for an increased risk of BPD associated with postnatal CMV infection. A much larger study was done across in a multi-center data set focusing on babies born under 1,500 grams. This was a case control study using a propensity score to match the cases to controls, matching on 16 different variables associated with the exposure and outcome. And in this study, the authors concluded that there was an increased relative risk of 1.33 for BPD associated with postnatal CMV infection. This same multi-center group went on to do another study in a more contemporary period going up through 2016. In this analysis, which included 273 cases and 273 controls, the propensity score was again used to choose the controls and extended to matching on 17 variables. But the point estimate was pretty much the same, with a relative risk of 1.3 for developing BPD in the setting of postnatal CMV infection. This last study also focused on a number of other outcomes. Specifically, the investigators found an elevated relative risk of 1.8 for a failed hearing screen at NICU discharge associated with postnatal CMV infection, and also found significantly longer NICU stay and a lower weight for age Z-score at discharge associated with postnatal CMV infection. The issue of postnatal CMV and necrotizing enterocolitis has been explored in multiple studies. Multiple studies describe a NEC-like illness as an expression of postnatal CMV infection. And there are case reports that document pathologic detection of CMV in resected gastrointestinal specimens in very severe cases of GI illness. The Atlanta group that had done the blood transfusion study reported on almost 600 infants that were assessed for postnatal CMV in a very recent report. This report included 33 infants of these 596 that developed postnatal CMV infection. They reported that necrotizing enterocolitis occurred in 18% of those with CMV compared to 7% of those without CMV for an adjusted cause-specific hazard ratio of 2.8. They also noted that exposure to higher breast milk CMV viral load was associated with a higher risk of necrotizing enterocolitis in this study. The issue of neurodevelopmental outcomes specifically attributed to postnatal CMV infection is complicated by the fact that most infants, as we have seen in this discussion, who develop postnatal CMV are also at relatively high risk of neurodevelopmental impairment on the basis of very low gestational age. And I'm not going to go through all these studies, only to tell you that many people have made the effort. Most of the studies have had a relatively low N of at least under 50 or under 100 infants. The age at which these infants were studied is different throughout them, and the different measures were used. And not surprisingly, there are different findings. Two studies that I list here found no significant differences attributable to postnatal CMV infection. Other studies demonstrated cognitive delay or evidence of brain changes on MRI attributable to postnatal CMV infection. I would like to highlight one study that was published in Pediatrics in 2018. This was a study of infants born at less than 1,500 grams in the Netherlands in the 21st century. The study had many findings. It was quite rigorously done, but limited by different tests done at different ages, a variety of exclusions, and reasonable loss to follow-up. It did have the advantage of testing all infants at term equivalent age to have a very thorough look at who was CMV infected during their NICU stay. I'd like to focus on 118 infants in this study who were born all at less than 30 weeks gestation and assessed at 6 years of age with a number of appropriate neurodevelopmental studies. Of these infants, 85 were CMV negative and 33 were CMV positive. No differences were found in motor development, but similar to the prior slide, there were impacts on cognitive outcome, with a lower verbal IQ noted among CMV positive children and a trend to a lower total IQ among CMV positive children. There is no evidence of an increased risk of sensorineural hearing loss in this study. So what is the risk-benefit to preterm infants? Can we or should we prevent postnatal CMV infection? Well, first, can we lower the risk of CMV transmission? Various efforts have been made to do this. Traditionally, folks had believed that freezing milk would lower the risk of CMV infection, and it's true that freezing does lower the infectious viral load in milk, but it does not eliminate infectivity, and probably for our most vulnerable infants does very little good. Holder pasteurization, heating milk to a high temperature for 30 minutes, is used in the preparation of donor milk, and it does eliminate CMV entirely, but alters the immune properties of milk. A recent publication reported on the use of in situ short-term pasteurization, so holding the milk to a high temperature for a very brief period in a special device. This has been described as significantly lowering the infectivity of milk and is associated with a lack of CMV transmission in a single center study in Germany. There's international practice variation that already exists around this topic. The Austrian Society of Pediatrics does recommend Holder pasteurization of seropositive milk samples for infants born at less than 1,500 grams and less than 32 weeks gestation. The French Food Authority advises pasteurization for infants if they're born under 1,000 grams or under 28 weeks, but only if born to seropositive mothers and only until about 32 weeks corrected gestational age. Many NICUs in Germany pasteurize milk, and it were these German investigators that have developed this device for bedside pasteurization and have demonstrated the clinical utility of using it. The American Academy of Pediatrics has, up until to date, has taken the view that the value of routinely feeding fresh human milk from CMV seropositive mothers and preterm infants overall outweighs the risk of clinical disease, especially because no long-term neurodevelopmental abnormalities have been reported. That statement still stands and reflects the continued uncertainty from the studies that have been published to date over the impact specifically of postnatal CMV infection. I'm not entirely certain how to resolve this, but the totality of the literature would suggest to us that we need to think about postnatal CMV as an opportunistic infection. That is, if we really should move away from a focus on CMV as a disease impacting the entire preterm population, defined as babies born less than 1,500 grams or less than 32 weeks, and really study the impact of CMV on those who are most vulnerable to harm. I would argue the lowest gestational infants, and specifically those who are exposed due to maternal status. If we did that, that would require that we determine maternal status on all infants who are admitted to our NICUs. Taking this type of approach would be akin to looking at the way CMV infection risk is managed in transplant patients, where very focused attention is given to the most vulnerable patients and only if there is evidence that they've been exposed in the course of their care to CMV. I think it's also fair to say that we cannot think of postnatal CMV infection as a linear issue, but as one that is an opportunistic infection, has many complex inputs. And what I mean by that is we know that there are multiple confounders that impact both the exposure and the outcome. We need to account for the vulnerability of the host, for the role of maternal immunity, and for viral factors that impact transmitting versus non-transmitting strains. In that way, we could design studies that would really focus with appropriate precision on how CMV infection is transmitted and how it may create altered immunity, inflammation, mucosal fragility, and tissue damage that may in fact lead to outcomes such as BPD, NEC, and neurodevelopmental impairment. So in conclusion, very low gestation infants are at risk for breast milk-acquired CMV infection when they're born to seropositive mothers. There's no evidence for negative impacts, there is evidence for negative impact on the risk of BPD, NEC, and neurodevelopmental outcomes, but that evidence remains subject to some debate. There are certainly benefits of breast milk feeding, and they have been established in a wide literature. Therefore, the balance, the overall risks of postnatal CMV infection remain somewhat unclear. And I would argue that a definitive multi-center study addressing the relationship of CMV with the risks of BPD, NEC, and neurodevelopment could determine the true risk-benefit balance for our most preterm infants. These are the references that I have used today in this presentation. And again, I thank you for the opportunity to present to you today.